Our next session, we're really honored to have Dr. Peter Higgins, who's the director of the Inflammatory Bowel Disease Program at the University of Michigan, join us. And he and Dr. Berkeley Limketkai, who is the new clinical research director of our Center for Inflammatory Bowel Diseases at UCLA, will be breaking down the top abstracts in IBD from DDW 2019. Dr. Higgins is going to do the first half, and then Dr. Limketkai will do the second half. So please welcome Dr. Peter Higgins.
Thank you for gathering up after that break. I'm sure we're going to talk about some of the hot topics at DDW this year and IBD. I'm going to cover the first three topics, PUCCINI, VARSITY, and Mirikizumab, and then turn it over to Berkeley for the rest. So PUCCINI is a long-awaited Crohn's and Colitis Foundation Clinical Research Alliance study to address do medications, IBD medications in particular, affect outcomes of surgery. And the basic design of the study is to get people shortly before they go to surgery, including an anti-TNF level, record all the baseline data, and follow them up after surgery, particularly focusing on infections, surgical site infections, and infections of any kind. And this is trying to address prospectively, in the best data set we've ever had, the controversies, particularly about anti-TNFs in surgery and do you have to stop. This is across 17 centers, 955 patients, data collected prospectively. I'm going to go forward. Sorry, we somehow exited. Let's try again. There we go. Okay. So in terms of the demographics, you can see that the folks who had anti-TNF use within 12 weeks of surgery were a little bit younger, a little bit less comorbidity, more likely to have Crohn's disease, shorter disease duration, and more likely to have azathioprine or methotrexate as co-therapies with an anti-TNF, and less likely to have vedolizumab or ustekinumab. Similarly, they had fewer prior abdominal surgeries. They tended to be sicker with more pre-op TPN, lower hemoglobins, lower albumin. So a lot of confounders that you'll need to adjust for in post-hoc analysis. And this is part of the controversy from all the retrospective studies. So looking at the surgery types, as you'd expect, almost half were ileocolic resections, several segmental small bowel or colon resections, and subtotal colectomies. And the basic results were colored by the anti-TNF exposure. And the nice thing here is that 40% had TNF within 12 weeks of surgery, 70% of those tested had a detectable TNF level, 77% if they were dosed within 12 weeks. So the majority of patients have some testing for TNF levels, so we can actually look objectively at that. And the top line data is that looking at any infection, whether they had TNF use or a detectable TNF level, had no effect on any infection. Whether they had TNF use that was detectable by a drug level for surgical site infection or by reported TNF use within 12 weeks, again, no effect on the outcome of surgical site infection. So if anyone says this is the big deal, but you could say, wait a minute, what about all the potential confounders? So Ben Cohen, who did this study, conducted several multivariate models and to control for all these confounders, and repeatedly, TNF use within 12 weeks of surgery was not a significant contributor. In this case, for patient-reported TNF exposure in any postoperative infection, what was really important was whether there was an abscess requiring a genitourinary fistula repair, pre-op infection, pre-op TPN, ureteral stents, smoking, and comorbidity scores, not surprising, all favoring infection. If you had detectable TNF levels, taking out the noise of whether people actually had TNF in their body, the GU fistula repair, pre-op TPN, and comorbidity score were most significant. If you break it down to surgical site infection, and they were exposed by taking an anti-TNF, again, ureteral stent, revision of resection, pre-op steroids a risk factor, and comorbidity score. And for surgical site infection, when they had detectable levels, urgent or emergent surgery became important, and pre-op thiopurines was slightly protective. So bottom line, we're not seeing a whole lot. Neither patient-reported preoperative use of TNF nor detectable serum TNF levels were independent risk factors for any post-op infection or surgical site infections. It's not perfect. It's not all patients. We had to have patients who consented, and they reflected whatever the prevailing practices were in choosing when to go to surgery. But preoperative use of TNF does not appear to be an important factor and should not affect timing of surgical decisions in IBD. Don't delay to wait for his TNF to wash out. Now I'm going to turn to the VARSITY study. This is our first head-to-head trial comparing two biologic therapies for ulcerative colitis. They compared vedolizumab, an IV gut-selective anti-integrin, to adalimumab, a sub-Q anti-TNF. This was a double-blind, double-dummy study, so patients were randomized to one arm where they got vedolizumab IV and a placebo sub-Q, so they didn't know which one they were getting, or adalimumab sub-Q and a placebo IV. So they got both sub-Q and IV, so they truly didn't know which one they were getting. And it's a very large study, 771 patients randomized. They had to be adults with UC who were more than 15 centimeters of colon, no prior adalimumab nor prior vedolizumab, up to 25%, and it worked out to be about 21%, had prior TNF, randomized about 380 per arm. Now you look at the top line data, you see that 61% in this arm completed treatment, 74% there. That's a pretty significant difference. You go back and look at how many people bailed out for lack of efficacy. It was 41 in the vedo arm and 82 in the adalimumab arm. That should be a clue that there's some difference there. Looking at the baseline data, they were pretty similar. The vedo folks had a little bit longer duration. In terms of TNF use, they were pretty similar. And severity, they were pretty similar. But the top-line data showed that for overall clinical remission, overall there was a big difference, significant difference, 0.006, for much higher rates of clinical remission with vedolizumab and ulcerative colitis. And this is the first time we have head-to-head data for this. That was held true as highly significant in the TNF naive. It was less impressive. The trend was there, but not significant for the TNF failures. Now, you could argue that this is a smaller sample size, has much less power, but it does seem like the delta gets a bit smaller. Not too surprising. These are tougher folks to treat. Similarly, for endoscopic improvement, big win for vedolizumab, highly statistically significant in the TNF naive. Again, the trend is there. It's not as impressive for the TNF exposed. What's really weird about this study, and this was the part where everyone sort of puzzles, is that if you look at steroid-free clinical remission, their third endpoint in their list of endpoints, everything flips. And so here you see higher rates of steroid-free clinical remission with adalimumab, overall TNF naive and TNF exposed, which is really puzzling. Why would that be reversed? So when they summarized the mean dosing, what's really strange about this is the folks on vedo came in on an average of 19 milligrams of prednisone, ended up at an average of 7.4 for a delta of 11.6. So they started out with higher doses. Adalimumab folks started at 17, ended up at 8.6. But it was really hard to get folks completely off that last 7.5 milligrams of prednisone in the vedo group compared to the adalimumab group. And I have a theory on why that is, but we'll talk about that at the end. The other thing they looked at was people who entered the trial without steroid use, big differences in favor of vedolizumab, without baseline immunomodulator use, again, favored vedolizumab as in the overall. But if they started on steroids or they started on immunomodulator, the differences weren't very impressive. So if you have to go with adalimumab for UC, starting them with steroid induction with an immunomodulator may help you out. Histologically, two different scales. There's a lot of argument about what the best histologic scale is, but both of them showed a large delta in favor of vedolizumab over adalimumab in ulcerative colitis. In terms of when that difference occurs, somewhere between 6 and 14 weeks, they significantly separate and they stay separated. So pretty early differences. In terms of safety, pretty similar in terms of overall adverse events. Some specific ones that were interesting for vedo, there's a little bit more Clostridia, quite a bit more herpes virus for adalimumab and URI infections, as well as skin disorders, mostly psoriasis in the adalimumab arm. So vedolizumab looked better for clinical and endoscopic efficacy in the treatment of moderate to severe UC. In the TNF experienced The trends held up but didn't reach statistical significance, partly because it was a smaller sample size. Steroid-free remission rates, and this is the weird one, were numerically higher with adalimumab, not significantly higher, but despite a greater decrease in steroid use and lower ending dose with Vedo. And with concomitant steroids and immunomodulator use at baseline, they were basically equal. So histologic efficacy favored Vedo, and improvements were somewhere between week 6 and 14. And my pet theory on why it was so hard to get the people off Vedo is a subset of people who just hung on to that 5 milligrams. And this was not part of the protocol. It was per physician choice. The physicians chose to leave them on that last 5 to 7 milligrams of steroids. We do have some data that anti-TNFs have an additional benefit on pain perception in the brain, and this is from an fMRI study from 2015. It's possible, although you'd have to go back and figure out why the docs did it, they were leaving them on the prednisone because when the patients tapered, they got pain. And that might be something you get more benefit from a TNF from than from an anti-integrin. Now turning to Mirikizumab, this is a new agent, an anti-P19, which is a pure anti-IL-23, unlike Stelara, which you're familiar with, which is an anti-IL-12-23. This is a pure anti-IL-23 that a number of companies think might be better, so there are a lot of these in the pipeline. They previously showed in phase 2 induction in Crohn's disease, and they had previous phase 2 success in both UC and psoriasis, and I'm going to talk about the 52-week maintenance data in UC. These are the previous Miri responders. Previously, the 12-week UC trial went well. So in terms of the phase 2 induction in Crohn's, they are looking primarily at endoscopic response, a 50% reduction in baseline in SCSG, as well as endoscopic remission, clinical remission by the PRO scores, and safety and tolerability. Randomized people to placebo and 3 different doses of mirikizumab, 200, 600, and 1,000, and the groups were largely similar. And they saw a really nice dose response in the phase 2 induction in Crohn's. For the primary endpoint of SCSG response, low rate in placebo, higher at 200, 600, and 800. Didn't quite reach significance with the 200, but the others were. Similarly, at the SCS remission, not quite significant for the 200, but quite significant for 600 and 1,000. So it looks like there's a dose response. 1,000 may not be the peak of how high we can go, but clearly benefit over placebo. For the PRO symptomatic remission, these tend to be noisier when you're dealing with patient symptoms, but again, significant at both of the high doses. The medium dose looks like it might be slightly better. And for CDI, another patient-reported outcome, differences between placebo and drug. In terms of safety, the main things that stood out, again, this is a smallish study with about 60 or 30 per arm, so we may miss things, but a little bit more headache, a little bit more arthralgia compared to placebo, and more URIs. So now I'm going to turn to the 52-week UC maintenance data. This is a long-term 104-week study. They reported the data at week 52. And these are folks with UC who have moderate to severely active. They're using 50, 200, or 600 doses, and then the responders are randomized to sub-Q every 12 weeks or every 4 weeks. Obviously, the company's hoping every 12 weeks will be just as good. We'll find out. So the initial UC induction results look quite similar to the Crohn's data, that it was quite a bit better than placebo, and maybe this middling dose would better on symptoms, and they saw good results for endoscopic healing. Then they randomized their folks to either 200 Q12 weeks or Q4 weeks. They had a little bit of trouble with the randomization. They had a longer duration in the Q4 weeks, but similar levels of severity. In terms of clinical remission, there's a trend at the Q4 week. The more often it was a little bit better, not statistically significant, but that held up for biologic naive and biologic experienced patients. And for clinical response, again, biologic naive and biologic experienced, the biologic naive had a bigger delta. And for endoscopic healing, the Q4 weeks does look a notch better. So all in all, it looks like dosing a little bit more often may make a difference in this drug, and drug levels may help. Endoscopic remission flipped the other way, which may be noise because the numbers are small, but there's certainly something to hope that a lot of patients might do well on the Q12. In terms of looking at the adverse events, there wasn't a whole lot of surprises, but you did see more worsening of ulcerative colitis in the less often dosed people, the every 12 weeks, suggesting that there are patients who really do need the more frequent dosing. So it's effective in the Crohn's induction in the 12-week study, prior efficacy in the UC induction at 12 weeks. UC efficacy maintained to 52 weeks, and it looks like a trend that the Q4 weeks might be better than the Q12. In terms of safety, you see a little bit more URIs, arthralgia, and headache at high doses, but nothing particularly worrisome. All in all, when you take this with the other drugs in this pathway, like risankizumab, guselkumab, it looks like pure anti-IL-23s are coming. It looks like they're probably going to succeed in phase 3. Barring any surprising safety signals, we're probably going to see pure anti-IL-23s on the market in the next few years as a new option for both UC and Crohn's. Now I'm going to turn it over to my colleague, Berkeley, for the rest of DDW and IBD.